Hi friends, I am Dr. Pratap Singh Rathod. I have done MD in Policy Medicine, and today we'll continue with regional injuries. In that, we'll discuss about injuries to the brain. Brain injuries or traumatic brain injury is the most commonly seen in motor vehicle accidents, falls, and assaults. Based on different criteria, it can be classified. Based on severity, it is classified as mild brain injury, moderate brain injury, severe brain injury, where the person may lose unconscious and may lead into coma. By mechanism of brain injury, it may be missile injuries, like any foreign object thrown in during explosions, or like a bullet, which may penetrate the brain, or blunt force injuries, where the person may be hit with a stone or any stick or any type of blunt weapons. Or pathologically, it may be because of primary injury or secondary injury. So primary brain injury caused at the time of impact. So any injury when there is a brain injury occurring at the time of impact of a assault or a fall like that, it is called a primary injury. Like there may be contusion, laceration, concussion, etc. Secondary brain injury is brain damage arising from events developing subsequent to brain injury. So any brain primary injury has occurred which leads to any further damage, that is called a secondary brain injury. In that includes hemorrhage, which may occur instantaneous. So one brain injury may lead to damage to the vessels and may lead to hemorrhage, that is secondary injury, or there may be delayed hemorrhage which may occur after a few hours. There may occur inflammation, brain swelling, axonal swelling after a primary injury. So those are all comes under secondary brain injury. Now coming to cause of brain injury, there are three different mechanisms by which there may be brain injury. One is penetrating wounds of the skull, fracture, distortion of the skull, then relative movements of the brain within the skull. So coming to penetrating wounds, so the skull may be penetrated by different foreign objects such as knife, bullets, etc., which may lead to brain injury. This may fragment the skull in also causing depressed fracture and cause the brain injury. Next is fracture distortion of the skull. When there is a localized segment of the skull undergoes deformation, shear strains may develop in the brain tissues underlying the indentation, and contusions may be produced in the surface layers of the brain. So whenever there is a localized distension or indentation because of any deformation, this distension fractures may cause the underlying brain damage, may lead to contusions. If there is a fracture occurs, the pieces of the bone fragments may penetrate the dura and lacerate the brain. Next is relative movement of brain within the skull. So this form of mechanism, in this the brain moves within the skull and lead to damage. So these are mainly the acceleration where the brain moves moving forward, or sudden deceleration where there is sudden stoppage of the brain may lead to injuries. So in this there is a sudden movement of the head due to injury which produces intracranial pressure gradients and subject the brain to both shearing and tensile forces. So impact force of the head can produce linear acceleration or rotational acceleration or combination of both. So any of the three may be there in acceleration, deceleration injuries. So in linear acceleration, the force passes through the line of the head, accelerating the head in a straight line. So linear acceleration is when where there is linear movement of the head. So for example, the person is driving in a car, suddenly applies brake, the body may move forward and head may move forward in the straight line. That is linear acceleration. In rotational or angular acceleration, the force does not pass through the center of the head, and thus head will rotate about its center. So in angular deceleration, the head may not move in the circular straight line, but maybe move in the circular fashion, in the rotational acceleration. In the impacts of the front and back of the head tend to produce linear acceleration. Examples are like if there is a head injury in the front side or back side, there will be linear acceleration occurs, while those in the side produces combination of linear as well as angular accelerations. Subdural hemorrhages and diffuse axonal injuries are producing these kind of injuries, which is commonly seen in this acceleration deceleration injuries. In either deceleration or acceleration, the skull and brain cannot change their velocity simultaneously. So mainly because of inertial actions, the skull and brain cannot change the velocity. So because the brain is inside the CSF, the skull moves in different way than the brain. So sudden stoppage of the head may not cause the sudden stoppage of the brain. So brain will still be in the motion, and the brain which is present will move in the direction of the force, and it may hit the skull, inside the skull, and injuries occurs. There may be skull injury, skull may hit, the brain may hit the skull, or brain may come in contact with the dura, and dura may injure the brain. The brain will slow down or speed up due to the restraint by the falx and tentorium, causing damage to the brain of the cerebrum, corpus callosum, and brainstem. So either the brain hits the skull, or brain may come contact with the falx cerebri, tentorium, or the dura mater, which leads to various types of brain injuries in acceleration and deceleration injuries. Silent symptoms of traumatic brain injuries. There are mainly four forms by which the brain injury may occur. One is axonal injury, that is, the axons get injured. Vascular injury may lead to hemorrhage and compression or edemal injuries. Hypoxic ischemic encephalopathy, where there is decrease in blood supply to the brains, leading to nerve damage and ischemia. Or there may be brain swelling, where there is interstitial fluids may get accumulated in the brain tissue, and brain may get swelled. So any three forms, these four forms may be there in the traumatic brain injuries. These categories may overlap, and they are often accompanied by various forms of focal traumatic brain injury. So any form of this may be accompanied with this, and overlap and side symptoms occurs because of traumatic brain injuries. Now coming to specific forms of brain injuries. First is cerebral contusions and lacerations. So contusions are areas of hemorrhagic disruptions of the sinews that are superficially located in the brain with the intact pia, which are called as contusions. So we should keep in mind the pia mater is intact in contusions, and within the intact pia there is hemorrhagic disruptions which cause the contusions. If the pia is torn, it becomes a lacerations with underlying lacerated brain. So cerebral laceration, traumatic lesions in which there is a loss of continuity of substance of brain. So brain continuity is lost in lacerations. In severe cases, extensive lacerations with underlying parenchyma hemorrhage forming burst may form the burst lobe. So extensive laceration may cause the uh, one of the lobe to burst and causing to burst lobe, which often are seen in the temporal lobes. They are usually surrounded by a group of contusions. So laceration may not be a isolated event, but it may be accompanied by multiple contusions. Contusions occurs usually in the frontal and temporal poles and on the inferior surface of the frontal and temporal lobes, and the cortex above and below the sylvian fissures. So these are the commonest area where the contusions are usually seen. Typically, it involves the crust of gyri and often involves the gray matter only. May also extend to underlying white matter and form a hematoma. So contusions may not be only involve the brain surface, it may also involve gray matter, white matter, and may also form a hematoma. Pathogenesis of contusions. Contusions are the sites where the brain tissue comes in contact with bony protuberances and dura covering. So as we understood in acceleration deceleration injuries, any acceleration and deceleration injuries may lead to the brain coming in contact with bony protuberance or dura coverings. Sites of forcible separations of the brain from dura may also cause contusions. So sudden separation of brain from the dura. Sites of differential movements between brain and dura, that is, brain is moving in one direction, dura is forced other direction, may also cause contusions. And between adjacent areas of the brain, so between the two areas, between two lobes, there may be fractures, there may be uh, brain may move with different directions and may lead to contusions. Contusion produces focal neurological deficits that may persist more than 24 hours. If damage is focal, it is localized, patients may recover uneventfully without any changes. But if it is accompanied by hemorrhages like subdural hemorrhage, then the person may lead to the symptom may become severe and lead to coma. Contusions are often seen in alcoholics. Alcohol is associated with unduly large contusions since it causes blunted protective locomotor reflexes. So as we know, alcohol causes incoordination of muscles, and persons is unable to move accordingly and may fall easily. In alcoholics, there is a chance of liver damage is present. There is also acute alcohol intoxication, and which hinders the hemostasis. So because of all these reasons, in alcoholics, contusions are easily formed and very large. Now coming to different types of brain contusions. One is coup contusions. So coup is a form term which is used to any injury which occurs at the point of impact. So contusions which occur the site of impact due to the in-bending, bone rebounding and injuring the brain. So this occurs because of brain rebounding against the bone surfaces and occurs at the point of impact of the brain. So if there is an impact at the frontal lobe, there is a hoop injury occurs at the frontal lobe. They have wedge-shaped appearance whose base is at the pile surfaces and tip is pointing towards the white matter. So if you take a cross section, the base of the injury will be in near the pile surface, the outer surface of the brain, and as we go inside, it becomes a cone shape with tip pointing towards the white matter. Next is contre-coup contusions. It is associated with falls and occurs at the site diametrically opposite to the point of impact. So if there is an impact in the frontal region, then diametrically opposite, that is will be the occipital region where there is an impact occurs. So this occurs because the brain is stationary, and when there is a sudden stoppage of the brain will move and it may hit the frontal region and it may go backwards. It is due to brain rebounding backwards from the skull following the impact. It is most commonly seen in the frontal and temporal lobes. So it is commonly seen in frontal where the person may fall in the backside and it may lead to brain moving in the forward direction and may lead to the frontal lobes. Next type of contusion is fracture contusions, which is associated to fracture of the skull. So any fracture of the skull, like depressed fracture, may lead to contusion underlying the fractures. In the intermediate core contusions, it is present in the deeper structures of the brain, like white matter and basic ganglia. It is present along the line of impact between the coup and counter-coup points. So any coup and counter-coup points may be associated with intermediate coup contusions, where between inside the white matter or near the basic ganglia, there may be smaller contusions may be present along the coup and counter-coup points. Then there is gliding contusions. These are usually associated with diffuse axonal injury and occurs independent of site and direction of impact. So these are not usually associated with the axonal injury, but it may, other than the site of impact, it is present. It is seen in falls and road traffic accidents. Next type of contusion is herniation contusion. It is due to impact of medial side of the temporal lobe with edge of the tentorum or the cerebellar tonsils against the foramen magnum. So this occurs because of impact of medial side of the temporal lobe with the edge of tentorum or cerebral tonsils against the foramen magnum. It is independent to the site or direction of the impact. Next, autopsy findings in contusions. In early stages, small contusion may appear as a linear hemorrhages perpendicular to the parietal surface and associated with focal swelling. So, in early stages, it may just appear as a linear swellings. Larger contusions may form lacerations which appear as fragmented and irregularly shaped hemorrhagic areas. Frequently, there is associated subarachnoid hemorrhage may be seen. With time, the contusions may shrink and take a golden brown color secondary to hemocytin depositions. Many times, old contusions are frequently seen in as a incidental findings in the alcoholics, where the person may have many fall, and because of that, multiple conditions may be seen which are healed, which are frequently found in the autopsy. Next type of brain injury is the concussions or cerebral concussions. Cerebral concussion is a physiological disruption of brain as a result of traumatic event which is manifested by least one of these followings. So concussion is not a gross finding, but it is a physiological disruptions. In this, there may be alteration of mental state, loss of memory, then local neurological deficit that may or may not be transient. So in concussion, one of the three findings may be present, like person may be or mental state may be altered, there may be loss of memory, or there may be neurological deficit may be seen. Concussion is also known as mild traumatic brain injury and is a clinical diagnosis. It results from acceleration deceleration of head, commonly seen acceleration deceleration of head. These violent head movements may cause shearing or stretching of nerve fibers, and axonal damage may occur. Many times it also resembles drunkenness. Concussion is commonly among most contact and collision sports events like football players, boxers, particularly exposed to repeated concussions are seen, leading to condition known as chronic traumatic encephalopathic syndrome. Now coming to signs and symptoms of concussions. In signs and symptoms, there is unconsciousness, bradycardia, hypertension, sweating, and it's always associated with retrograde or post-traumatic amnesia. So person may either lose the memory. Temporary lethargy, irritability, chronic dysfunctions are seen. Muscles are flaccid, pupils are dilated, unreacting, pulse is weak, slow, and respiration also shallow. Concussion is also associated with different forms of syndromes. One is post-concussion syndrome, in which the patients who return to work too early, seen in the patients who are returned to work early after work. It consists of headache, vertigo, lassitude, irritability, depression, which may persist for months. Then there is post-traumatic automatism. In this, it is intimately associated with amnesia, that is loss of memory. After the accident, the patient may speak and act in purposive manner, but does not remember anything later on. So in this, there is antegrade amnesia, where there is loss of memory subsequent to the event that caused the amnesia. That is, for after event, he doesn't remember anything. Retrograde amnesia is loss of memory preceding the event, that is, before the event, he will lose the memory. Next is punch-drunk syndrome. So this is also called as dementia epileptic or Boxer's encephalopathy. It's a condition occurring late in boxers where there is which is correct, which is because occurs because of cumulative results of recurrent cerebral concussions. There may be deterioration of speed and reflexes and in coordination along with personality change associated with social instability, sometimes paranoia and delusion. The person may have some paranoid activity, like he may think that someone is trying to kill him. Delusion may be present. There may be chronic subdural hemorrhage, minor smaller hemorrhage may be present. Attenuation of corpuscularianism, diffuse axonal energy, and cortical atrophy may be seen. In findings, gross findings in light microscopic changes in the brain are usually absent, but biochemical and ultrasonic structural changes like mitochondrial ATP depletion, local disruption of blood-brain barrier may occur. CT and MRI scans are usually normal in case of concussions. Next form of brain injury is a diffuse axonal injury. In this, the cellular damage is seen. So axons are injured in these cases. So diffuse axonal injury is a clinical pathological condition. So grossly, there may not be change, but it is a clinical condition where sign symptoms tells the person has some axonal injury. And pathologically means if you see under microscope only, you can find axonal damage is seen. In this, they represent the spectrum of severity in which there is a victim is unconscious from time of injury and either remains in a coma or enter a persistent vegetative state. So severity varies, and the person may be either remain in coma or remain in the persistent vegetative state, where he is unable to respond to stimuli. In severe cases, patient may expire depending on the severity of concurrent secondary injury. It results from relative movement or the gray white matter. So between gray and white matter, when there is a movement change in the when they rub each other, then changes occurs. Following sudden rotational or acceleration deceleration forces, which causes disruption and tearing of axons, myelin sheaths, and blood capillaries. With concussions, the axonal damage is considered as irreversible. However, when sufficient vital axons are severely injured, then death can occur. So, in only minor concussions, axon damage is considered reversible, but when there are vital axons, so many axons are damaged, the person may die. 90% of cases are due to road traffic accidents and 110% due to falls and assaults. Autopsy findings in axonal injury, there may be contact injuries to the skull may be present. So, outerlying skull or scalp may be injured, which and with underlying axonal injury. Thin subarachnoid hemorrhages may be seen. In brain, there may be particular hemorrhages in corpus callosum, focal lesions in dorsolateral aspect of rostral brain stems. Then there will be gliding conditions are common, and hemorrhages in thalamus and vesica ganglia are frequently present. Diagnosis can be done by CT scan, with characteristic scan be seen. In severe cases, focal lesions are seen, particular hemorrhages in corpus callosum, cerebral peduncle, and diffuse injury may be seen. MRI and histologically it is diagnosed by demonstrating the numerous axonal swellings. Next form of brain injury is the brain swelling or edema of the brain and swelling. In brain swelling, edema is mainly intercellular. In edema of the brain, the fluid is collected in the interstitial tissues. Swelling of the brain may occur following any significant head injury, which may be focal, which is localized adjacent to an area of brain injury, or diffuse involving both cerebral hemispheres or involve the one hemisphere only. And signs symptoms usually similar to that of concussions. Next is cerebral compression. So cerebral compression occurs when there is any form of injury, like any increase in the size of the brain, example generalized swelling or space occupying lesions within the cranial cavity results in compression of brain. So any space occupying lesions like a hemorrhage, subdural hemorrhage may be present, or a local tumor may be present. So those all leads to cerebral compressions. As the brain is incompressible, the compression will diminish the amount of CSF in the subarachnoid space and in the ventricles. Continuous rise in the intracranial pressure leads to progressive interference with the blood supply of the brain, leading to brain damage. Next form of injury is the coup and contre-coup injuries. So coup and contre-coup injuries are typically seen in any acceleration deceleration injuries. So whenever the skull and the brain are stopped, there is chance of coup and contre-coup injuries, and this occurs because brain is floating in the CSF and sudden stoppage may make the brain to move forward and backwards. So coup injuries is one which occurs immediately beneath the area of impact, results directly by the impacting force. So any injury which at the time of impact occurs is called as coup injuries. The effects are immediate, resulting in contusions and hemorrhages. For example, if the head is fixed, that is person standing still, and there is a violent impact over the frontal bone. So if the person is standing still and there is a stick injury occurs at the frontal bone, the fracture and underlying brain damage will be located beneath the site of impact. So at the site of impact only brain damage occurs, that is coup injuries. Counter-coup injury means that the lesion is present in the brain opposite to the site of impact. It is caused when the moving head is suddenly decelerated by hitting on the firm surface. Example, striking of the head on the ground during a fall, usually seen in the road traffic accidents. So the sudden stoppage of the brain may lead to counter-coup injuries where brain may hit the moving surfaces. Sudden arrest of the head resulting in the injury to the brain which is still in motion, striking the arrested skull. So the head is moving in the forward direction but it suddenly stopped, then the brain will be moving in the backside because of inertia and lead counter-coup injuries. Mechanism of counter-coup injuries occurs due to local distortion of the skull and sudden rotation of the head resulting from the blows which causes shear strain by pulling a part of the constitutive of the brain. It can occur only in head when the head is free to move. It occurs most frequently in the temporal lobes and frontal lobes, especially the orbital surfaces. It is rare before the age of 3 years. An impact causes cavity or vacuum in the cranial cavity and the opposite side as the brain lags behind the moving skull. So sudden impact of the brain causes sudden vacuum formation leading to movement of the brain. The vacuum exerts a suction effect which damages the brain. A blow which produces in bending of the bone displaces the brain to the opposite side, causing the striking against the skull. For example, when a person falls with the occiput striking the ground, he may sustain injury to the occipital lobe, that is coup injury, and a more prominent injury to the frontal lobe, that is contre-coup injury. So, in this example, if there is an injury in the occipital lobe, there is maybe prominent injury occurring in the frontal lobe. So, one example is when sudden stoppage of the head by the striking object like a baseball hits the front lobe, there will be injury in the front lobe, that is the coup injury. And one more injury like as I mentioned in the example, person is falling on the occipital lobe, the sudden stoppage of the brain may lead to the brain may rebound from the brain inside the skull and may hit the frontal bone and may cause a counter-coup injury in the front lobe. Medical legal importance of coup and counter-coup injuries. On the basis of localization of injuries, it is possible to conclude if they are resulted from the fall or from the blows. So, how the coup and counter-coup injuries has occurred can be determined based on the where the lesions are present. With blows, that is assault, brain shows much larger contusions underlying the area of impact, that is coup injuries, than the side of opposite of the impact. So usually counter-coup injuries will be less prominent than the coup injuries. So at the point of impact, the swelling will be more compared to counter-coup injuries. Counter-coup lesions are rare, but in head injuries caused by falls like rotator accidents, the counter-coup injuries are usually located in the inaccessible portions and are larger than the coup contusions. So sometimes counter-coup injuries may not be seen directly below the opposite to the coup injuries, but may be seen below the inside the brain. Coup lesions may be absent or minimal in certain conditions. Now coming to cause of death in head injuries. In all the types of brain injuries, usually respiratory failure or passage is followed by permanent cardiac arrest is seen. Other mechanisms is markedly raised intracranial pressure, that is cerebral compression, may also lead to coma and death. Others are infections because of fractures, hypostatic pneumonia, pulmonary embolism, and renal infections are other causes of brain death in brain injuries. These are my references. Thank you.